traumatic brain injury. Gilsevere MD, M.Sc. Contents Epidemiology Biomechanics of Primary Brain Injury. Mechanisms of Secondary Brain Injury. Clinical classification of head injury. Treatment modalities, past, present, and future. Controversies. Epidemiology 2 million pints/year evaluated in U.S., ed. 220,000 admissions/year. 100,000 temporary or permanent disability. Additional 30 to 50,000 die before ed arrival. Peaks 15 to 25 years. O and greater than 65. Death 3.4x more common in males. Most common, MVCs and gunshot. Physiology, hemodynamics. Oxygen consumption -20% of total body. Requires 15% of normal cardiac output. CBF, 50 milliliters/100 grams per minute. Autoregulation. Maintain BTWN MAP 60 to 150 or CPP 50 to 160. Hyperton, acidosis, hypocarbia equals VC. Hypoton, acidosis, hypercarbia, hypoxia equals VD. Physiology, ICP craniospinal space non-expandable. Sum of brain, CSF, and blood constant. Insults. Brain volume, edema. CSF, obstruction. Blood volume, ICH, hematoma, VD, congestion. Compensation, up to 50 to 100 milliliters. CSF displacement first. Brain elasticity. Physiology, CPP equals MAP, ICP. Less than 40 to 50 autoregulation lost/vasoparalysis vasodilation and ICP decr. CPP. As ICP approaches MAP CPP ceases cell death. Brain injury dynamic process of primary injury secondary injury. Occurs at time of head trauma. Irreversible. Prevention strategies. Secondary injury. Minutes to days post-injury. Therapy directed at limiting this further brain cell death. Biomechanics, primary injury. Direct injury. Impact by object or compression mechanism. External signs of trauma. Skull-plastic deformity absorbs energy fracture if force sufficient. Transmitted force to brain tissue. Injury pattern, skull hash, epidural, contusion. Associated indirect injury other injury pattern. Biomechanics, primary injury. Indirect injury. Cranial contents set into vigorous motion. Acceleration/deceleration, rotational, angular forces. Bridging subdural vessel strain. Differential acceleration, shear injuries. Impact of brain on inner aspect of skull. Injury pattern, subdural, die, concussion, countercup. Secondary injury. This is where we intervene to limit further brain cell damage. Mechanisms. Systemic insults. Intracranial lesions. Neuroendocrine disturbance. Membrane failure. Abnormal ion fluxes. Edema, secondary injury. Pathophysiology of TBI. Primary brain damage. Energy. Failure. Glutamate. Release. Lactate. Acidosis. Membrane. Failure. Massive Ca. Entry. Brain. Edema. Free radicals. Release. Vasodilatation. Increased. CBV. Increased. ICP. Neuronal. Death. Secondary brain damage. Secondary injury, preventable. Treatable secondary insults to the brain in trauma patients include CPP, goal greater than 60 mm of mercury. Hypotension, goal SBP greater than 90, not related to head injury. ICP, goal less than 15 to 20. Hypoxia, goal PAL2 greater than 60 mm of mercury. Can be head injury, brainstem, or other airway/breathing/oxygenation/ventilation. Anemia, goal HCT greater than 30%. Seizures, increased metabolic demand. Secondary injury preventable. Edema, local/global CBF disturbance. Diffuse, comprimus ventricles, loss of sulci, effaced basal cisterns. Focal, hypodensity around lesion plus/shift. Vasogenic, BBB failure, direct injury to cell membranes, penocytosis and osmotic gradient. Cytotoxic, membrane pump failure, hypoxia, ischemia. Clinical classification. Determined by post-resuscitation GCS. Minimal, GCS 15 and no log/amnesia. Mild, GCS 13-14 to 15 with log/amnesia. Moderate, GCS 9 to 12-13. Severe, GCS 8 or less. Severe head injury severe, GCS 8 or less 10% of all TBI 40% mortality. 25% require neurosurgical intervention. Severe head injury CT findings subdural -30% epidural, 0.5 to 1%. Subarachnoid -33%. Intracerebral hematoma -12%. Subdural hygroma -10%. Treatment airway and breathing BP hyperventilation. Hyperosmotic agents. CSF drainage. Surgery. Seizure prophylaxis. Moderate head injury moderate equals GCS 9 to 12-13 10% of all TBI. 20% mortality. Classification of close DBI. Diffuse TBI. Focal TBI. Skull. Fractures. Intracranial. Hemorrhages. Brain. Contusions. Brain. Concussion. Diffuse axonal injury. EDH. SDH. ICH. Brain edema. Increased ICP. A major threat, increased ICP. Linear skull fractures. Depressed skull fractures. Skull deformation. Compression of brain. Higher risk of bleeding. Depressed skull fractures. Complications. Wound and CSF infections. CSF leak. Neural injury and deficit. Base skull fractures high energy loading CSF leak and infection. Cranial nerve damage. Acute epidural hematoma. Lucid interval is suggestive. Good prognosis. Acute epidural hematoma. Most often due to skull fracture. Brain damage is uncommon. Acute epidural hematoma. Acute subdural hematoma. Always associated with significant DBI. Often grim prognosis. Acute subdural hematoma. Massive edema is the rule. Disproportionate midline shift. High mortality and morbidity. Brain contusions. Coup and contra coup. Brain contusions. Pathophysiology. Brain contusions, pathology. Evolving brain contusions, the patient WHO talk and die. Subarachnoid hemorrhage. Diffuse axonal injury. Pathophysiology. Diffuse axonal injury, the disconnected brain. Diffuse axonal injury, the disconnected brain. Diffuse axonal injury, the disconnected brain. Gunshot wounds, E equals MC2. Gunshot wounds, E equals MC2 directly depends on velocity missile. Through and through usually fatal. Associates focal and diffuse TBI.